Good evening, everyone. Thank you for joining us tonight. Welcome to the Avexia webinar series. Our topic for tonight's special webinar is overmethylation, the missing piece of your hormone puzzle. My name is Joanne Iverson. I am the Director of Client Relations for Avexia Diagnostics and will be your host for this evening. Today, I have the distinct pleasure of being joined by an exciting guest, Dr. Jean Lawrence, who will be our presenter for this webinar. Dr. Lawrence is a nationally recognized speaker on the subject of whole food nutrition and is a certified clinical nutritionist, master herbalist, certified functional medicine practitioner, doctor of naturopathy, doctor of naturopathic medicine, has a PhD in natural medicine, and a diplomate of the American Clinical Board of Nutrition. She has several years of experience with whole food nutrition, herbal nutrition, functional blood work, hormone testing, and hair analysis. She specializes in endocrine disorders and digestive issues. She co-manages patients with several practitioners and offers telehealth visits as well for her out-of-state patients. Her functional medicine practice in Toccoa, Georgia, with her husband, Philip, a chiropractor. Her passion is teaching and training other practitioners, and she brings education, information, and entertainment together in a unique style. Dr. Lawrence has been the executive director of the American Clinical Board of Nutrition and is a member of the advisory board of Functional Medicine University. Joining Dr. Lawrence tonight will be Dr. Wayne Sedano, our Director of Clinical Support and Education at Avexia Diagnostics. Additionally, Dr. Sedano is the Director of Integrative Medicine Education for the College of Integrative Medicine and lectures and teaches internationally. Before we begin, just a bit of housekeeping. We do encourage participation. So if you have a question, you may submit your question in the questions field in the right-hand area of the interface. We will answer submitted questions towards the end of the presentation. If you'd like to follow along with Dr. Lawrence's presentation, there is a PDF handout in the interface. If your questions are not answered this evening, you will surely receive an answer by email within a day or two. Without further delay, I now turn the webinar over to Dr. Lawrence.
Well, good evening, everybody. Thank you for tuning in. And I'm very excited to be offering my first webinar for Avexia. And hopefully you will join the other ones as they become available through the rest of this year. And my passion, as Joanne was saying, is teaching practitioners all the stuff, the cool stuff that I find out about, share it with you so that together we can help more patients than any of us can by ourselves. I love what I do. I hope you love what you do, because helping people and changing lives is the most rewarding thing any of us can do. So I have been a proponent of the Dutch test for a long time now, and I love it, love it, love it. And I was starting to dig deeper and finding out some more information, and I thought this information needs to be shared. So I hope you really enjoy this tonight. All right, so here's our typical disclaimer. We know it hasn't been evaluated by the FDA, and of course doesn't replace the advice of a licensed medical professional, and we're not treating, curing, or diagnosing anything. All right, here we go. So first of all, what is methylation? Now, the first time I heard about methylation, I was watching a webinar given by the gentleman that wrote the paleocardiologist, I'm sorry. And he's just wonderful. So it was about migraines, and I thought, okay, anything to do with headaches, I want to hear it, because I want everybody to never have a headache again. And so I started listening to that and found out what methylation was, and there was no stopping me after that. I was thinking, this is amazing. Why isn't anybody talking about this? Because a lot of information that I've attended, no one ever brings this up, and it is so, so, so important. So we know that we're not going to get boring tonight. We're not going to get into all the histone tales and all this other stuff, so don't let this slide frighten you. But methylation is fascinating, and it's just unbelievable information. And so when you start to dig a little bit, and it's like, okay, this really lights your fire, and you want to go to the next step. So most people that you're going to see in your office, they are familiar with MTHFR, methylene tetrahydrofolate reductase, and it's a genetic SNP, as we know, a single nucleotide polymorphism And the way to tell this to patients, because we know they're not going to be on this level, right? The way I explained a SNP to them is to say you have enzyme A. It has to change whatever the problem is into enzyme B. It has to just, that's what it has to do. It just has to take the product and it has to change it from A to B. That's what genetics do. So when there's a SNP or a problem with changing it, that's where we get genetic SNPs. And so it just means I can't take substance A and make it into substance B. That's all it means. And of course, we can blame our parents. We do probably blame them for everything anyway. And you know, your kids are going to blame you for everything anyway, too. So everybody's just saying, oh, well, I can't help it. It's genetic, no matter what their problem is. But we know that genetics load the gun, but environment pulls the trigger. So just because we have genetic SNPs doesn't mean they're necessarily going to activate. And that's why we study epigenetics, which means above genetics, so that we can have answers so that these genes don't express. Now, everybody you talk to that's into this kind of thing is going to say, okay, everybody has MTHFR, blah, 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 blah. We need to put them on, you know, methylfolate and methylcobalamin and all this other stuff. We need the methylated form of the B vitamins. Well, actually, according to Dr. William Walsh, we're going to talk about him tonight. According to his research, only 22% of the population actually has MTHFR. Now, I think that has probably changed due to our environmental toxins that we're exposed to and just our food supply and all that. I think that's probably gone up since he had that number. But everything in our practices and that we read about is focused on MTHFR and getting people to methylate better, right? So, okay, well, this is fine. But when I first heard about overmethylation, I had a patient that I have a board in my office, a whiteboard that has methylation pathway on it, and I never erase that. That's always up there. And I was explaining this to her, and she said, oh, I can't take B6. And I said, oh, why not? Oh, well, it just really messes me up. I can't do it. And I said, okay. So as I was talking to her, this was very interesting to me. And I said, well, how do you know you can't take this? She said, well, I tried to take it, and besides the symptoms that it gave me, she said, I have to take 10 times the amount of something for it to work. Okay, so if somebody takes 1 Tylenol, I have to take 5. And if I start to drink, I can drink everybody in the room under the table. And she told me she went to the dentist once for a procedure. She took 3 Ativan and drove herself home from the dentist. Oh, that never happens. How could, I think 1 Ativan would put most people in a coma for a few days, wouldn't it? But she took 3 and drove herself home. So this intrigued me. I thought, okay, I've heard of fast, metabolism and all this and fast doing that. No, I thought there's got to be something else going on with this. So I started to dig a little deeper, and Dr. Walsh's book that I'm going to mention is an excellent, excellent resource. And he's the first one that I actually read about overmethylation. So this is interesting that 8% of the population actually has this issue, but it's never discussed. I don't understand that. So we're actually crowding out the people that are desperately needing our help. And I'm going to tell you about the signs of this and how to spot this on the Dutch test and all this information for you so you can help more people. Okay, so this was a book that was written about in the late 90s. And I found it because I was just searching Amazon for anything to do with methylation, and there's still tons of other books. But this was excellent. But this guy, his whole career as a PhD was studying methylation. And he talked about all the amazing things that you need to support methylation other than just B vitamins, okay? Which was very interesting to me. I'd never heard those things mentioned either. It's always the same trifecta, right? Of B6, B12, and folic acid. And that's all we're ever told. But this guy gets into more and more depth about the other nutrients that you can be adding to support methylation. So I loved that about this book. So this is an older book, but it's still relevant. Now, this was Dr. Walsh. I believe he has passed away now. Isn't he sweet? Look at his picture. So this book is amazing, and he called it Nutrient Power. He said this because nutrients change physiology, as we know. So I think that in our society, we have it all backwards, right? We tell people, don't do this and don't do that and don't do that. Well, what if you tell your patient to quit eating donuts? What are they going to do when they leave your office? They're going to run to Krispy Kreme, and they're going to grab a donut because you told them not to. Well, he said, if we change the physiology, behavior will follow, and that is so true. So like when they took soft drink machines out of the high schools and the test scores got better and everything, they were changing the physiology and the behavior followed. So this is what he talks about in his book. It's one of my go-to books all the time, and you just never get tired of reading it because he had a database full of 1 million lab results, and he dealt with prisoners, serial killers, all kinds, schizophrenics, bipolars, about all kinds of people. Amazing, amazing, amazing. And he had a clinic where he would help these people. And he found that basically they were deficient in nutrition. So let's help more people to not have to take these antidepressants and anti-anxiety pills and all this stuff that makes them have behavioral issues, right? And that could really show out in their behavior and sometimes very publicly. So I highly, highly recommend this book. And I've watched his videos and he's just like everybody's grandpa. He's just sweet. Okay. So this was the woman I was telling you about, that she drove herself home from the dentist and she had taken 3 Ativan. And I thought, do you ever get a patient that you've been taught, okay, here's the rote thing we're supposed to do. They come in, it's going to be that. Well, then you get somebody that just throws you for a loop. But I love that because it takes you down the road less traveled. And that's what overmethylation is. It's something that a lot of people aren't familiar with. They don't even understand low methylation to start with, and that's okay. But they think, well, how can something be overmethylating? I don't understand. And what do I do about it? That's why we're here tonight. Okay. Now, so if the patient also has COMT, and we know about MTHFR, but what if they've been on this support for a really long time? Doesn't that lead to something down the road? Does that mean they're always going to be undermethylating? Or can they get to a point where it tips the scale and now they're overmethylating? Well, that's what can happen, okay? So they may have been taking B vitamins for a really long time, don't think anything about it. So I have a chiropractor friend. He lives about an hour from me, and one of his children is a high functioning autistic child. And he said, my son is having a meltdown. We don't understand it. And I said, do you have him on methylation support? He said, yes. And I said, it's going in the opposite direction. Give him some niacin. And the kid calmed down. Kid, young guy, right? Like 20. Now, so this is what can happen to your patients. If you find out initially that they're undermethylating, you give them the support, but they're taking it for years and years and years, and now they're starting to have some issues. Well, how do you know that, right? The Dutch test is amazing because it talks about this in the report. So if you're not using the Dutch test, it stands for Dried Urine Test Comprehensive Hormones. And there's so much cool information on there that you would never see in a blood test. So we can't assume that just because someone is, not methylating or low methylating, that they're going to stay that way forever, because they keep pounding in those B vitamins, something's going to happen. Now, this is one of my favorite slides. Don't let it scare you, okay? Because, I'm not a biochem major, but I still love to see the pathways. So here we're going to look at the circle in the center that says methionine. Okay, so we know this is an amino acid, and it's going to it says magnesium right next to it, right to the right of it. Okay, so now it's going to cycle into SAMe, and then it's going to go down and it's going to make homocysteine. Okay, and then it's going to cycle back up, and you see on the left hand side it says B12 right there. Okay, now here's what's interesting. You see in the middle of the circle, it says betaine. What is betaine? Well, it's usually betaine hydrochloride, isn't it? So if your patient is taking a PPI and they're too alkaline, do you ever have those patients that are like, I'm just going to alkalize everything, right? I'm just going to alkalize my liver today. Well, how are you going to do that? your stomach must be acidic. And who knew that betaine would actually promote good methylation? So your patients that are taking PPIs and antacids are going to have problems with methylation. So it cycles back into methionine, but let's go back down to the homocysteine, and also the folic acid is necessary here, okay? But now you're going to go down past homocysteine, and it says CBS. Okay, what does that mean? That's a genetic variant that can cause a problem converting homocysteine into the next step, which is cystathionine, and then cysteine. Most of us have heard of N-acetylcysteine, which is the precursor to glutathione, okay? And all to the right, you can see taurine, which is amazing. I hope a lot of you are doing amino acid testing. We're going to talk about that because taurine helps things like SVTs, right? Supraventricular tachycardia. It also helps things like diabetic neuropathy, diabetic retinopathy. It also helps congestive heart failure. Are we told this kind of stuff? Not every day, right? And I know you're having patients with those issues. So now it goes with, here's the B6, right? So it keeps going down. We're going to talk tonight about this SUOX genetic SNP where the sulfites are supposed to change into the sulfates. And you see the little MO at the bottom there, and that's for molybdenum. And we're going to talk about that because that's a big deal in overmethylation. So when I have a patient in my office, I'm not going to explain all this to them because, you know, we see people from all walks of life, don't we? We see cashiers and truck drivers and CEOs, and we see everybody. So I don't want to overwhelm them with too much information because basically your patient wants to know a couple things. First of all, can you help me? Second, how much is it going to cost? And third, how long is it going to take? All of your patients want to know that. So they don't need to know all of this information, but this is why I leave one whiteboard in my office blank, because I draw out for them what's going on with them specifically. But my methylation whiteboard, it's been there so long I can't even erase it anymore, okay? So it just is fascinating because we know that low methylation can lead to problems like allergies and histamine issues and migraines and increased risk of heart problems because of the homocysteine being elevated. There's all these things that we're just focused on and we've been taught before, okay? But especially this bottom part with the sulfites to the sulfates, and of course the CBS genetic variant means the person has to take B6, okay? They just need B6. Well, what depletes B6? Well, for example, blood pressure medications deplete B6, asthma medications deplete B6. So now if your person is taking any of these things, they can't detoxify. I always tell the patient, you know, your trash in your body goes into a can. You can't roll the can to the curb, okay? The truck is coming, but your can isn't there, so the truck just keeps on going, and then you're toxic. I love this slide because it just shows you the difference between these two. So because we're focused on overmethylation, let's talk about this one, paranoia. Do you have any patients that are dealing with paranoia, especially since the past couple of years? Depression, food sensitivities. You know, you get some people that's like, well, I'm down to broccoli. Okay, that's all there is left. And it can't just be the stalk, you know, it has to be just the flowerets on the top. It has to be just broccoli. It has to be steamed, you know, can't be boiled. I mean, people have severe food issues, don't they? Sleep issues. Okay, this is just this output of cortisol can be going on. High anxiety, artistic. Now that's interesting. They have sometimes artistic capabilities. Low motivation. Do you have anybody like that? Are you like that? You have low motivation. They're constantly thinking. These are your patients that say, I lay down at night and my mind is just going and going and going and going, and I wish it had an off switch. Okay, it's just these ruminating thoughts, just on and on and on, like a cow chewing its cud. They just keep thinking and thinking and thinking. They have tried an SSRI for depression. It does not work. How many of your patients have been on multiple things? You know, I like to tell my patients that no one has a Prozac deficiency. Okay? I mean, the world didn't say everything's going to be better when they invent Prozac. No, it goes back to nutrient deficiencies. Plain and simple. But how many of your patients want to fix right now, and they don't want to wait a few weeks for the nutrition to kick in. Most of them, right? We've become a drive-through microwave society. We want everything right now. But with methylation changes, it's going to take a little bit of time, but the outcomes are wonderful. All right, common symptoms of overmethylation. Now, you will get all these notes if you didn't download them tonight with the handout thing. You're still going to get them, okay? So you don't have to write everything down. Okay, so here's what we talked about just a minute ago. The paranoia, depression, artistic or musical ability, upper body, neck, or head pain, heavy body hair. Now, what are you thinking? You're thinking more androgens now, right? You're thinking PCOS, okay? Food and chemical sensitivities, sleep disorders, they don't do well with estrogen therapy. I'm going to explain why they don't. They have an adverse reaction to antihistamines. That's for low methylation. Those are the people that take Benadryl to sleep, which scares me to death. Okay. What's it doing to their liver? I'm frightened. They do better with the benzodiazepines. They could be cutters, okay, and also have a lot of tattoos and piercings. They can't take the SSRIs. They have a high pain threshold. I had a patient who was 30. He told me he put down hardwood floors for his job during the day, but at night he was an MMA fighter, okay? And I said, and this guy was like 5'8", maybe 135 pounds. I said, don't these other guys just beat you up? He said, oh yeah, but I recovered within like an hour. Amazing. So they have a very, very high pain threshold. Of course, the ruminations, like I talked about, they have a tendency to panic attacks. I'm sure you don't have anybody in your office that does that. Pacing or constant movement. These people can't sit still. I know you're already thinking. I can feel you thinking out there. You're thinking about your ADD patients, your ADHD patients, right? That's what's going on. Now, this, we know about the Dutch test. If you don't know about the Dutch test, I highly recommend it. I used to do blood testing for hormones. Sorry, kind of a waste of time. Didn't get enough information. I want the most information that I can get from a test for the amount of money that it costs. And this fit the bill, okay? So it just has so much cool stuff in it. Now, they just collect 4 or 5. The last one is optional. So it's 4 is necessary. 5, the 5th one is optional. Dried urine samples, okay? And they stay stable for about 3 weeks. So it comes with all the samples and it gives the patient complete instructions in the kit about the collection, how much water to take and limit yourself to, and how much caffeine. Now, why would that matter? Because if they're drinking 5 gallons of water a day, it's going to dilute the urine too much and we can't read the hormones. If they're also taking a lot of caffeine, what's that going to do? It's going to raise their cortisol. And then we're going to get a report that's not exactly accurate. So they also include a bag with a free UPS label on it. So the patient, it's easy to ship back to the company for them to process it, and very easy to do, okay? So if you're not familiar with this, they have a ton of also online education on their website, on the Dutch Test website. But with Avexia, you can order it along with ordering other things for the patient right then. Now, there is a version called Dutch Cycle Mapping that takes 9 samples. And these are for women that cannot conceive, or they're having hormones that they just feel like they need to have a period, but they're not having a period. Maybe it's an anovulatory cycle. The ovaries are still there, but the uterus is gone. Their cycles are all over the place. The PCOS, PMS, mid-cycle, they're having a period. I had a patient once that had bled for 300 days straight. What kind of a nightmare would that be? Terrible, okay? So that's when this is really working very well, okay? The cycle mapping is not for birth control pill users, obviously, because they don't want to conceive, and then of course on hormone replacement therapy. But I use this for my females that are saying cyclical migraines, migraines during ovulation, just having trouble during ovulation, okay? It's another version, because this one, the basic one, is called Dutch Complete. And if you do Dutch cycle mapping, you can do the version that's cycle mapping plus the complete, and then you get the adrenals, the sex hormones, the downstream metabolites. It's just so cool. Okay, this is what one of the cycle mapping graphs would look like. And at the bottom, very bottom, that doesn't show on this slide, they will tell you the normal amounts of estrogen during the different phases of their cycle. So it's really neat to see what's happening in ovulation. And then you can say, okay, you need to take this or that during these days of your cycle, and works very, very well. But look at this hexagon here and look at all the stuff that is showing you on this test. The cortisol awakening response, the free cortisol pattern. Now look to the right-hand side, it's kind of in a turquoise color. It says 8-hydroxy-DG. Now, what the heck is that? This is one of the most important markers you can run on a patient, and it's only done in urine, okay? What does this mean? This tells you the patient's oxidative stress level to their cells. You're not going to get that in a blood test. You're not going to get that in saliva. Okay, this is awesome that it's included on this test. Their melatonin, their waking melatonin production. This is why they can't get up in the morning. They're making too much melatonin. Their testosterone, their androgen metabolites. So then you can spot PCOS way ahead of time. Progesterone, the organic acids, okay, dealing with some of those. Estrogen metabolites, neurotransmitter metabolites, and cortisol metabolites. That's a lot. And it's a urine test. How hard is that? I like to tell patients when I hand them the test kit, if they're in my office, I'll say, now this isn't mine, it's urine. And then, of course, they chuckle because, you know, people are more at ease when you can get them to laugh about something. And I used to have a little cartoon on my desk that said, I've already diagnosed myself on the internet. I'm just here for a second opinion. Yeah, I know you guys are all feeling that one. Okay, they all come in, they already know. It's my thyroid, I swear it's my thyroid. No, it's actually your pituitary, you know, but let them think what they like till we straighten them out. Okay. Now, anxiety can actually occur from overmethylation. Now, this is an actual patient that I had, age 20, and I'm going to show you some information on her test. Okay. So if the person shows overmethylation, I'm going to show you what that looks like. I do not use high doses of B6 because they're already overmethylating. And I recommend folic acid and B12 sometimes. Okay, depends. If I don't want to make the methylation worse, I'm going to cut back on the folic acid B12. And there's ways to know that. Okay, so this is what people, they can drink a big, huge thing of coffee and go right to sleep. Okay, but this can also be an arginine deficiency. Now, what does arginine do? This is dealing with the urea and ammonia detoxification cycles. And we're going to see that when the person has low molybdenum and a molybdenum deficiency, they're actually going to show low uric acid on a blood test, which is kind of cool. Okay. Now, this girl is 20. Now, this is how I explain this test to a patient. All of their results are in the white circles here. Okay. Now, if you see this little purple box where it says hormone testing summary right there at the top, and the sex hormones, we're looking at one of her estrogens, estradiol. The little purple box is the postmenopausal range. This girl is 20. Okay, she's the hormones of a 70-year-old. Now let's imagine for a moment that this girl had gone to her regular doctor and they had said, oh, we'll just run your hormones and a blood test. And they had seen that her blood levels were very low. What would they have said? Oh, we've got to put you on something. Let's put you on birth control. Let's put you on hormone replacement. At 20, honey, she ought to be knocking it out of the park at 20. Okay? She ought to be just good to go. Look at her progesterone, also in the postmenopausal range here. Nope. How would you explain this? Well, the first thing you might think is it's going to be a thyroid issue. It's going to be an ovarian issue. No, actually, it's a liver issue. So the testosterone, normal for her age, but look at her adrenal hormones. Now, here's where it gets really interesting. You see this rectangle here? She is the red line. You think she's tired? Yeah, she's tired because she's not, her waking up is way at the bottom. Morning is a disaster. Afternoon, she finally gets with it. Nighttime, she's up. Okay. Now, to the immediate right, her 24-hour free cortisol, it should be 65 to 200. She's below that at 62. No energy. Now, let's say she'd done a saliva test. Let's just imagine that for a moment. And it comes back that her cortisol is just nothing. What's the doctor going to do? Oh, we need to give you adrenal glandular support, and we need to give you, licorice, herbal licorice, and we need blah, blah, blah. No, because look to the far right and the circle that says 3518. This is her total cortisol production. Her adrenals are fine. So why does she have low daily cortisol? Why does she have low sex hormones? I'm so glad you're asking these questions. All right, this was her symptomatology. Well, she's tired. Well, duh. She has irregular cycles? Well, of course she does. She doesn't have any estrogen or progesterone to regulate her cycles. So of course they're irregular. She also told me that she was having a lot of digestive issues. Now, why would this matter? You would think high cortisol would cause digestive issues because when we're in fight or flight, sympathetic response, we're not going to be in parasympathetic, which is resting and digesting. But estradiol actually controls the amount of HCl production in the body. Incredible. So she doesn't have enough stomach acid to break her food down because she doesn't have any estrogen. This girl is a fast track to osteoporosis and she's 20. I hope you get people like this. I really hope you do, because then you're going to get excited. You're going to say, okay, I got it. Then you're going to be a rock star. If you're not already, you're going to be, and everybody's going to love you. Okay. So this is what we would suspect. Pituitary failure, right? Telling the ovaries, forget it. Thyroid failure, ovarian failure, everything else. Her thyroid test, normal TSH, which is debatable. I believe in 1.8 to 3 is what I like to see, but low total T4. Okay, well, she needed a little bit of iodine, but let's think for a minute. Just hold that thought about the low total T4. Okay, total cortisol production, but 24 hours very low. What's going on? Okay, now this is page 3 of this report. Here's where it gets fun. Now look on this page at the very bottom and the lower left-hand corner that says methylation activity. Now, does that look low to you or normal? No, it's in the high end. So then you would think, oh, this is great. She's methylating extremely well. No. Okay, this is why all of her hormones are this low. So now her liver is overactive, okay? And so this could be from years of taking methylated B vitamins or also toxic load, which I'm going to explain, and the need for increased liver clearance of hormones or toxins. Okay, so we know if she went to the doctor, they would want her to take HRT, and she'd feel great for a couple weeks. And then she'd call them back and say, I'm not any better. And they'd say, well, we don't understand why you're not any better. For example, what if progesterone is this low in a 20-year-old? What are her periods going to be? She's going to have heavy periods. They're going to come too often. She might have 2 or 3 a month. If she gets pregnant, it's going to be a miracle. But to keep a baby to term, not going to happen. Okay? So look over at the pie chart on the right-hand side. Now, this is strictly how the liver is processing the estrogens. That's all it's doing. It's not saying other things that the liver does. So everybody has all 3 pathways here. Okay, the green is protective. Underneath, her green percentage is only 45.2%. It should be 60 to 80%. The red one is slightly toxic, 13.3. She's a little bit above the 7.5 to 11. But the blue is the most highly toxic, and hers is at 41.5%. So all her estrogens, then there aren't that many, are going down the wrong toxic pathway. And sometimes this can push the liver to overmethylate. Okay. Now, when you read through the Dutch report, we know that the first 6 pages are basically the results for the patient. And when I have a patient, that's all that I discuss with them are the first 6 pages. But now you read through the rest of the information, which is about 11 more pages. It's wonderful because it's talking about what the person's adrenals are doing, and it's for you guys to read. It's not for the patient to understand. It's for you guys to decipher. But there's nothing in that report about overmethylation. Now, what does that mean? Does that mean that they don't know about it or they haven't read Dr. Walsh's book? Because there's a lot of information out there about overmethylation. So I don't understand that, because I have read those reports over and over and over and over, and all they will say is methylation is fine and move on. No, it's not fine. Okay, that's why we're here tonight. This is a huge issue, and I know you're seeing this in your patients. Okay, because you can give a woman all the chase tree and all this other stuff you want until the cows come home. But if you don't do this test and see what's going on with their methylation, you're not going to help them. Okay. So I love that the Dutch test looks at methylation, but I want them to address overmethylation, because this is happening. It's only going to be in a certain percentage of your patients that you do this test on, but it is there. It is there. And these people have some serious issues. And so we need to work on this. Okay. All right. Now, if her hormone levels are this low, what's she going to have? Postmenopausal symptoms, dry skin. Can you imagine vaginal dryness at 20? Well, that'd be real fun, wouldn't it? Hot flashes. You have patients in your 20s and 30s that are coming in with hot flashes? Absolutely. Okay. Brain fog. And now it's told it's all in your head. And here comes the psychiatric referral. And now they're on drugs, and we all know the drill. Okay. So the doctor's trying to help her, but they can't figure this out. So they go, I don't know what else to do with you. Go see somebody else. Do you ever get patients like that? I love the kind of patients that nobody else wants. Now, the ones that say, I've tried everything, I've been everywhere, what is going on with me? Because I like to be the detective, and I hope you guys like to be the detective too, because it's fun and it's rewarding. Okay. Now, here's the biggie about this. Remember when I said to hold on to that T4 being low? Okay. Her sex hormones are being metabolized too quickly. This explains the low estrogen and progesterone. The 24-hour cortisol is also being removed too quickly. Her adrenals are going, we're fine. Okay. Don't need to mess with us. Something else is going on over there. Not us. Thyroid hormone is also being removed. How many of your patients are having their thyroid medication adjusted every 10 minutes because TSH goes up and goes down and goes up and goes down, and they can't figure that out? Okay. And the patient doesn't ever feel any better most of the time anyway. But it's also can mean that insulin is removed too quickly. Okay. So now we have higher levels of blood sugar because the insulin isn't being released to bring it back to normal, and diabetes is not getting better, and now they're on insulin. Because insulin is what? It's a hormone. What is thyroid? Hormone. All these things are happening. That's what I love about this. I'm like, wait a minute. This doesn't just mean the sex hormones. This can mean all the other hormones, cortisol and insulin. And that was kind of an epiphany for me. Now on page 6, I want to point this out because this is going to start to make you think. Okay, so then this is the old stuff that they used to check. Now they're checking like a whole bunch more stuff on page 6. Okay, so dopamine levels are measured. Now you can see the B12 on here says it's within range, and B6 and her glutathione. But here's her dopamine below range. Now, what are the symptoms of low dopamine? Guess what? You don't like people. And so when I have a patient that I'm talking to either on the phone or in the office, I'll say, well, your dopamine levels are low. This means you probably don't like people very much. And they always laugh because it's true. They have no motivation. That sometimes they have addictions because this is a reward center of the brain. Well, what do we need to make dopamine? Well, we need some B6. We also need niacin, and we need iron. So if the patient is anemic, they won't make dopamine, and then they don't like people. Okay. Now, the Dutch information says that BH4, tetrahydrobiopterin, and iron are required to make dopamine. This is true, but you also need niacin. Now, niacin has been shown to raise homocysteine. Now, most people are like, oh, I don't want my homocysteine to go up. Okay, but it means it slows down methylation. That's why homocysteine goes back up. So what if you have a patient and their homocysteine level is a 2? It's pretty low. You might be thinking, wow, that's amazing. No, well, not always, because they can be overmethylating. But it slows down methylation, and this is the preferred recommendation for overmethylation. Okay? So think about it this way. Folic acid and B12 are going to speed it up. Niacin is going to slow it down. Now, it doesn't mean you leave them on niacin the rest of their life. One of the best things to do would be give folic acid, B12, and niacin together, wouldn't it? Then you have it kind of covered, whether it's low or high. But if your patient is taking niacin and is a poor methylator and they don't know it, it's actually making methylation worse. Okay, let me say that again. If your patient is taking niacin and they are a low methylator, niacin is making it worse. They don't need to take niacin then. Okay, and then they need to get back on their B12 and folate. And Dr. Walsh talks about low folate depression. This is why some women feel better when they're on prenatal vitamins, because it has folic acid in it, and they feel so much better. So you've got to get his book and read about that. Now, so this is why I was saying, when you have the blue part of the pie chart, this is showing a toxic form of estrogen, and sometimes this can cause the liver to overmethylate, get stuff out of there as fast as possible. Okay, so the body's trying to produce more glutathione. Remember, we have the homocysteine, and then we have the cystathionine and the cysteine, and then downstream from that is glutathione, which is the major antioxidant made in your liver, which is amazing. And the body's trying to get it to make more glutathione to get rid of these toxins. Now, what are the best things to get rid of this blue part of the pie chart? We want to change it towards more green and less blue. Well, flaxseed, okay, in a smoothie, or flax oil. Fiber, fiber, fiber in the diet is going to help to bind this up. Some people use Biodim, which is diindolylmethane, and then you can also use calcium D-glucarate. All of these things are going to help shift this picture around, okay? So when we go back to this, look at the bottom number here. Look at the bottom here, where it says oxidative stress. There's that 8-hydroxy-DG, okay? It's the high end of the range. She's almost at the top, and she's 20. She already is showing cellular damage from something. Damage to her mitochondria. What is this coming from? Where's this coming from? Okay, so this is why I tell the person that high levels of poor estrogen metabolism are going to come from 3 basic things: plastics, drinking out of plastic bottles and plastic exposures. This includes breast implants, people. Okay, they're all encased in plastic. Bug sprays are estrogenic. I don't know if they want to grow the bug bigger before they kill it. I don't know what the reason is behind that. And then, of course, meat that isn't always organic or grass-fed. And you must ask your patients about pesticide services. You must. Okay? That's a given. Anybody I talk to, I'm asking about major toxic exposures. But if you see this, and you see this woman has a high end of range of this DNA damage marker, I want to tell you how accurate this is. I had a patient that his number was a 12 here, a 12, okay? And his total cholesterol was 100, which is frightening in itself. And I said, I'm doing a cancer panel. And he said, fine, let's do a cancer panel. And it came back that he had a marker elevated for pancreatic cancer. That's how accurate that number is. Are you going to find that on a blood test? No. So if your patient has a history of breast cancer or breast cancer in their family, and they need to be doing this test. All right, now, these are more symptoms about overmethylation. High anxiety. Now, when I say that, I want to go back to this just a moment. Look at the dopamine again, where it says below range at 2.6. Now, sometimes in overmethylation, the norepinephrine and epinephrine is going to be elevated. Now, when dopamine converts into epinephrine, it requires copper and vitamin C. Copper and vitamin C. Now, if this person has a copper overload, and Dr. Walsh talks about that too, high copper means high anxiety. Well, where do we get copper? Copper water pipes. I ask about a copper IUD. Okay, really low levels of zinc. But copper is very agitating to the nerves. It's very agitating to the nerves. And then this is also affecting changing those sulfites into sulfates. And these people have major reactions to sulfur containing foods, garlic and onions and all. It's just a mess. These people it's pitiful. It really is pitiful. Okay, dry eyes and mouth. Hirsutism, facial hair. Non-competitive, low libido, talkative, obsessions without compulsive actions. Sleep disorder, food and chemical issues, estrogen intolerance, like we said. Postpartum depression. Ooh, I'm so glad you asked me about that, because I'm going to tell you where that comes from. So when a woman is pregnant, she creates copper to grow red blood cells and estrogen to grow the fetus. What does estrogen do to the gallbladder? It thickens the bile. It shuts down the thyroid function. But if it thickens the bile, the gallbladder is not going to work, and she has morning sickness. Okay? If you have a patient that ever has postpartum, I even ask my patients about if they've had any morning sickness with any of their children. And some of them say, oh my gosh, it lasted the whole 9 months. This was an inability to clear excess copper. If they have excess copper, this is one of the major reasons for overmethylation. Okay, you can run a serum copper test on a blood test. You can add serum copper. You can also do ceruloplasmin, which is another form of that, and see what their copper levels are. Okay, it's amazing what high copper levels is doing to people. Okay, so antihistamine intolerance, all this stuff we talked about before. Nervous legs, paranoia, all that stuff, and also testing blood histamine levels. This is why you do organic acid testing. It's really cool. Okay. Now, what about leaky gut and overmethylation? It seems like if you just look at a stop sign, you've got leaky gut, doesn't it? Everything, you just pick up a newspaper anymore. Who would even buys a newspaper anymore? It seems like everything causes overmethylation. But let's look at this pathway, okay? Here's your patient on a PPI, pantoprazole, omeprazole, whatever. Now they can't break down their proteins because there's not enough acid. Remember, betaine promotes methylation. Poor protein metabolism leads to excess ammonia production in the body. It's affecting the urea and the ammonia detoxification pathways. So the normal process of breaking this down is going to create some ammonia, then urea, and now we look at blood urea nitrogen in lab work. Okay? So if you have a patient that has normal creatinine, normal GFR, but their BUN is too high, they're having a problem breaking down proteins. This is why they tell a kidney failure patient to eat a low protein diet. No, let's just break down the proteins. How about that? Okay. So now you take a PPI, it only increases the amount of ammonia produced, which leads to leaky gut. This has been shown. Okay. So now we talk about supplements for healing the gut. Is L-glutamine. I looked this up because I want to know why stuff works, not just that it works. And L-glutamine works because it decreases high ammonia levels. Oh my gosh, that's amazing. So your patient can get leaky gut just from taking a PPI. They don't have to have antibiotics and NSAIDs and stress and all that other junk. They don't even have to have any of that going on. All right, so now we have less conversion of tyrosine to dopamine. Remember, tyrosine is above that, which requires the BH4, and ammonia chews up the BH4. BH4 is a byproduct of folic acid produced by healthy gut bacteria. So now here's your patient with depression or anxiety that can have low dopamine and overmethylation because that's not being converted. Now, I want you to read this through a few times and you're going to go, wow, I got it, I got it, I got it. Okay. But here's what's interesting. 90% of the time on the Dutch test, you're going to see this pattern. You're going to see overmethylation at the bottom left-hand corner of page 3, and you're going to see low dopamine levels on page 6. Over and over and over. Why is that? Because they both require niacin. This is awesome. I've had so many, this girl told me after I did this for her and put her on some niacin and stuff, she was like, I have my life back. I feel like I'm 20 again. Isn't that what we want? Isn't that why we're doing this kind of work? Listen, maybe you want to retire at 30. You're going to be bored by the time you're 31. Keep working and serving other people. It's the only thing worth doing. All right, so we know that there can be other drivers of leaky gut. Traumatic brain injury, antibiotic use, all that kind of stuff. And also food sensitivities cause leaky gut as well. No one ever talks about excess ammonia. You know how to ask your patient this? Does your pee ever smell strong to you? Do you ever have bubbles in your urine? Those are signs of poor protein breakdown, okay? So now the excess ammonia is driving leaky gut. Well, we know that leaky gut is the driver of what? Inflammation. And inflammation means what? High cortisol. And now the sex hormone levels drop. When cortisol goes up, the hormones go down. Now, why is that? Do you think that a person who's stressed out should have a baby? No. Aren't they going to have a harder time conceiving and keeping a baby to term? Yes. So you see how it starts with a PPI, which leads to ammonia, which leads to leaky gut, which leads to cortisol, which leads to low sex hormones. Okay. Once your patients grasp that, it's like, I got it, I got it, I got it. Okay. So then 24-hour cortisol is low, even though total cortisol production is normal, and you're telling your patients to take all this adrenal stuff, and they've got 15 bottles of adrenal stuff at their house, and they're saying, what's wrong with me? What's wrong with me? Lower dopamine means lower niacin, and now the overmethylation continues and leads to hormone levels that aren't corrected by adrenal supplements, hormone replacement, bioidentical hormone replacement, or thyroid medication. This is also required for the conversion of phenylalanine into tyrosine. What are the symptoms of low tyrosine? Brain fog, fatigue, feeling cold, increased cholesterol, and weight gain. This is why it's in thyroid supplements, because they think this is a thyroid problem. Okay, well, it is. It's being affected by it because the thyroid hormone is being flushed out. Okay? So then they're saying, I give you all this stuff. Why doesn't any of it work? You have to find the root cause. This is what functional medicine is, isn't it? Isn't that fun? I hope you're having fun with this. I love it. So according to the book Methyl Magic, this is what's needed for proper methylation. Betaine. These are the amounts for you. Okay? Choline. Now, how many of your patients have non-alcoholic fatty liver? A bunch. What's the number one reason for that? The non-alcoholic is insulin resistance, isn't it? Okay. Choline helps to break down the fats in the fatty liver. But choline is also there to promote methylation. And choline becomes what? Acetylcholine, which is a neurotransmitter that affects memory. So your patients with fatty liver have a choline deficiency, or they've had their gallbladder taken out, and they have a choline deficiency. Now they're not going to methylate properly, and now they're going to have memory issues. Now, what about their insulin resistance? That can just come from long-term high cortisol, because all that sugar is being put into the body, now they become insulin resistant from all the insulin having to be pumped out. And even if they never ate a Snickers, because you know Snickers is packed with peanuts, it really satisfies. Okay, but didn't even touch a Snickers, didn't even look at the wrapper, and now they're diabetic and they're thinking, how did this happen? Came from cortisol. Okay, so the inositol, choline and inositol are fat-soluble B vitamins that are incredible. Folic acid, B12, vitamin E, zinc, 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 zinc. Because if you have high copper, what do you need? That's right, you need zinc. Very good. B6, selenium. Selenium is also required to make glutathione. You need 4 atoms of selenium to make glutathione. And it's also required for the conversion of your thyroid hormone into the from the inactive T4 into T3. That is active. You can start using it. I looked at so many supplements. They don't have all of these ingredients in these doses in one supplement. So if anybody out there is putting something together, there's your formula right there. Okay. So according to this book by Dr. Karazian, these are the signs of low dopamine. They don't care if they finish anything, they start everything, they finish nothing, they feel worthless and hopeless, they're snapping at their kids or their partner, they can't handle stress. Yeah. And here's this poor person with this low dopamine. They can't handle stress, they want to be away from other people, they don't care. They don't care about family and friends. Somebody might say, oh, the neighbor's dog got hit. And they'd be like, really, what's for lunch? They don't care. And you'd be amazed how many of your patients are in that boat. Okay. So like I said, I started noticing the connection between methylations being in the high zone on page 3 and low dopamine being on page 6. This is what dopamine does. It's the reward center of the brain, makes you happy. Okay. It's also regulating prolactin. That's kind of important. Mood, attention, and learning, motor coordination. Parkinson's. What do they give Parkinson's patients? L-Dopa, right? Keeps away depression, social anxiety, and they just don't care. They just like, well, going through the motions, okay? And also learning. We know that these things such as high estrogen, high cortisol can lead to low levels of progesterone. Why does this affect your sleep? Because progesterone controls GABA production in the brain that is affecting sleep patterns, okay? And also they can't procreate, they can't carry baby to term, but it also can come from low dopamine, which comes from overmethylation very frequently. Is this starting to connect? Are you guys tracking this? I hope you are, because when I found out this information, I was like, oh my gosh, this is what I've been missing. So now you can have a woman who is having low progesterone, and it's because she's overmethylating. It's not because she is estrogen dominant. Aren't we stuck on that? Everybody's estrogen dominant. Well, a lot of people are, excuse me, but not everybody. But high cortisol, that's a whole nother webinar, okay? But if the dopamine is low and the progesterone is low, this can be all from overmethylation. So if a woman's having mood swings and the other symptoms of low dopamine and miscarriages, please do the Dutch test on them. It just gives you so much more information and clues to fill in your puzzle. Now, what's going to hinder dopamine? Anemia, okay? Everybody's looking at hemoglobin and hematocrit, and unless you're below lab range, you're not anemic, even though you're as white as the background to this slide and you're freezing all the time. No, you don't have anemia, okay? So ferritin, I include ferritin. This is included in the Avexia panels, is a major, major deal, okay? Because if the patient is dehydrated, hemoglobin and hematocrit are going to be elevated. Then you miss the anemia. But ferritin is not affected by dehydration. So look at that. The level for a cycling female should be 100. I've seen it at 2. Okay? Iron absorption is increased when there's adequate HCl. Okay? And also tell your patients not to take iron near gluten or dairy consumption. They block iron absorption. I hope this is all making sense to you. Now, this is what I was talking about. If the patient has had a cholecystectomy, they cannot break down their fats. But what do they say? You have fatty liver, and what do they tell you? Eat a low-fat diet and exercise. That's their answer to everything. No, 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 no. We need some good fats, but we want to use the fats that we're eating. What if you're eating avocados and olive oil and, oh, yummy, right? And you're not breaking them down, absorbing them. What are you going to have? You're going to have dry skin. You're going to have joint pain. You're going to have all these things. So putting the patient on bile salts is a supplement, and also eating beets. Real beets, not canned, okay? Real beets are going to help thin the bile. Awesome. But if the triglycerides are 200 and the total cholesterol was 210, that's fatty liver right there, okay? But also you want to make sure that all this stuff is working. You need fats to make hormones. You need cholesterol to make hormones. I mean, yeah, okay. So this is what I was saying about insulin resistance. That's the #1 reason for non-alcoholic fatty liver. We have to have phenylalanine to become the tyrosine and dopamine. It is hindered by insulin resistance. The #1 thing you need to help in your patients is their sugar, and that's the best way to help their adrenals too. So fatty liver, you take the choline with the bile salts. Lovely, lovely, lovely. So your patients with non-alcoholic fatty liver are actually having methylation issues. Okay? Now, if epinephrine is high, let's go back to this. Dopamine was low, but let's say the epinephrine was high because all the dopamine was converting into that. That's the copper overload. Okay? So you can add the serum copper or ceruloplasmin, and this is a major deal with your anxiety patients. Are you asking your anxiety patients about a copper IUD? A history of that? Are you asking them that? You should. And it's going to overconvert the dopamine, and now it's going to further the symptoms of low dopamine, and they hate everybody and they don't want to be around anybody. But no, we have to put them on something else for their mental health. No, no, no. Let's just find the signs of imbalances. This is the way I tell people what I do. People that come in to see me have imbalances. My job is to test to find the source of the imbalances and correct it with nutrition. Isn't that just the easiest way to tell people what you do? Because that's what we should be doing. People they don't go around and say, oh, should I take just one B vitamin by itself? Well, you don't eat a bowl of thiamine, do you? No. Eat better. The better food you eat, the less supplements you have to take. Okay. But if you have excess copper, you can't just start out with 100 milligrams of zinc. No, you got to start real slow. 10 milligrams a day, titrate up slowly. Okay. So this is why I ask about the pipes in their house. I currently have an 81-year-old female patient that has a movement disorder. So I know you guys can see me. This is her all the time. Can you imagine? This has been going on since 2015. She's been to 70 doctors. They've done brain MRIs. There's nothing wrong with her brain. When you talk to her, she's incredibly intelligent. But this is going on. Okay? Her methionine is too high. Okay? All of her aminos are just, they're just, the methionine stuff is too high because she's overmethylating. But all of the other aminos are just low, low, low. She's just not getting enough amino acids. And her taurine is low. And she's also having seizures. There's so much cool information. The whole cool thing would be test the person's copper in blood work, get some amino acid testing going on, and do the Dutch test. And you're like golden. Okay? So high copper levels can affect the adrenals because they're very irritating to the nerves, the liver, the blood sugar, the hormones, everything. Okay? And also, if you have low zinc in a patient, which would be low alkaline phosphatase on the labs, this can just be from excess copper. They might say, I'm taking zinc. I have too much copper. But also about the morning sickness and the postpartum depression. All these things can be tied into this because now it's affecting downstream the sulfites converting into sulfates. Okay? Because they have tied a copper overload to low molybdenum. Well, now what is molybdenum? It's a trace mineral. Okay? So if the person has too much copper, here's another cool thing. You're going to see, like I said, low uric acid on a blood test, which I said at the beginning. Low uric acid. Well, aren't we always happy when we see low uric acid on a patient? Oh, goody, you don't have gout. Yeah, but you might have something else going on. It should be normal. It shouldn't be too low or too high. And also another sign of overmethylation is you will see on blood work is high bilirubin. Well, what is high bilirubin? This is red blood cell destruction. So you're thinking spleen most of the time because that's what the spleen does. Pulls out old red blood cells that are and just recycles them, right? Gets them out of circulation. So spleen support is okay, but what if the patient has Gilbert syndrome? And they don't even have a reason why people have Gilbert's. It could be because they're overmethylating. Okay, they can't convert the sulfites to the sulfate. This is a sign of overmethylation. And a molybdenum deficiency will show up as low uric acid. Okay, there's just so many cool things that tie this together. So you're going to help people because they're having all these issues and they can't pinpoint it. So when you see either high epinephrine and norepinephrine on the Dutch test on page 6, low dopamine, high methylation levels on page 3. Okay, now you've got something to work with. Look at these symptoms of copper overload. And tell me this isn't your patient's. Acne, allergies, hair loss, anemia, anorexia. I'm not going to read all these things. You guys can read. Look at this, dysmenorrhea. Male infertility and prostatitis. Very interesting. Fibromyalgia. That also can come from other things. Migraines, PMS, chronic infections. Look at all these things. Okay? So when you're stressed out, you deplete zinc and magnesium, which makes copper overload even worse. All right. Now, B6 is necessary to convert dopa into dopamine and the conversion of homocysteine into cystathionine and then on to glutathione. If you see low levels of B6 here, the second marker down that they're checking, low levels, you would give B6, and that's the dose that I like every day. And you might see as well higher levels of 8-OHDG. Why is that? Well, if your glutathione level is low because of low B6, you can't detoxify, so what happens to your cells? They're going to be more damaged. They're going to be more open to oxidative stress, right? That's what's going to happen. So the less glutathione you can make, the less ability you have to detoxify, and the more toxins build up. Now we have more inflammation, more cortisol, and the whole thing starts over again. Okay? So then the sex hormones go down and life isn't fun anymore for a lot of people, and they're always telling you about that. And then it also can affect those detox pathways we saw on that pie chart on page 3 and lead to overmethylation. Okay? Now, if B6 levels are too high and it leads to overactivity of that CBS genetic variant between homocysteine and glutathione, this could lower the methylation and increase ammonia production. See, it just, okay, so I hope this wasn't all clear as mud, because once you get this and you start reading the slides, you'll be like, okay, so that means that, and then that means that. And it will make sense, okay? Because the best thing is to test and see what you've got going on with the patient. All right, now, overmethylation compound would be niacinamide to mop up excessive methyl groups. Folinic acid. Some people do not do well on folic acid by itself. It's a synthetic. Folinic acid is obviously going to help methylation. B vitamins, and here's what should be included in that, right? The riboflavin 5-phosphate, which is active B2, calcium pantothenate, B5, or pantothenic acid, it's also called that. And these are the references that I mentioned here. So John Neustadt wrote a book called A Revolution in Health Through Nutritional Biochemistry. It's about 100 pages, and it's amazing. I've probably read it 3 or 4 times. And it's just wonderful, because he's talking about the pathways we're talking about tonight, about the conversion into dopamine and norepinephrine and all this other stuff. You don't want to have high copper and low molybdenum and low niacin, because that's going to really mess people up. And they're going to say, I've tried everything, I've been everywhere. But this poor woman with this movement disorder, okay, she doesn't need hormone replacement usually at 81. I mean, unless she just wants that. But what's going on with her? She's so, her nerves are so irritated by this copper, and that she can't convert her sulfites to sulfate. It's just causing all this anxiety. All this stuff is on PubMed. It's just unbelievable how much this is happening, and nobody's paying attention to it. This is why I like to bring the stuff that other people are ignoring. Okay, we've all heard the same stuff. Trust me, I've been in enough seminars and webinars. I know the drill. I sit there and listen to people all the time. And a lot of times it's just the same old, isn't it? Nothing against the people that are presenting it. Great. But it's like, isn't there more than that? Isn't there more information that could be used here? We don't want the same old stuff. We want to learn something new. I thought this was incredible. Because just for example, number 2 here, Dr. Gilliams is incredibly smart. And in his book, he talks about that niacin lowers homocysteine. I mean, it raises homocysteine. That means it slows down overmethylation. But the proof is in the pudding, isn't it? You know, you can talk about this stuff and say, yeah, but it doesn't really work. Yeah, it really works. Because I've seen this in my clinical practice over and over and over again. Now, I want you to be thinking outside the methylation box, right? I don't want you to just assume everybody's a poor methylator. Here's your folic acid, B12, see you later. Nope, you need to do testing. I never give methylation support without testing. And some of your patients don't want to be tested, which is ridiculous. It's like throwing spaghetti on the wall and hope some of it sticks. Nope, okay? But no practitioner knows everything. None of us do. We all have our areas of expertise that we love. And so if you ask questions tonight and I don't know something, I will admit to you, I don't know that, but I will really, really try to find the answer to that. So I think we're a few minutes ahead, Joanne, so that we can actually take some more questions. So whatever you'd like to do, I will be here to answer questions.
Wonderful. Dr. Lawrence, I'm just going through some of the comments and questions, and there are quite a few that we will have to get to you. Just a lot of feedback. You are a delight and a wonderful speaker, and so many thank yous in here. Um, let's see if I can throw out a few questions, and then we'll just wrap up with ordering and just how to contact us here at Avexia. Let's see. Um, Anything else to treat overmethylation besides niacin? Does flushing with ERE niacin indicate anything?
Yes, so obviously no flush niacin is better. But besides that, actually I use a combination sometimes of niacin and B6, just because the B6 can be used up as well because everything's just being flushed out. But those are kind of my go-tos as far as slowing down methylation. And I've just seen that work over and over and over. Now, what if the person has normal dopamine, but they have overmethylation? This could simply be just a toxic driven problem. And once you start correcting the toxic pathways, of course, B6 helps to make the glutathione. Maybe that's all you want to do is just B6. And then you find out that their toxin load is a lot better. And then the methylation improves on its own, right? So it's not like it's a go-to and you have to do it every time. I've just seen that this pattern exists between the low dopamine, which needs niacin, and the overmethylation, which needs niacin. But yeah, that's just basically one of the simplest things to do. So I do something called niacinamide B6, and I do one a day. Works great.
Thank you. Here's just a comment. Amazing webinar, mind blowing. Mind blowing. So just to be clear, high copper is the major cause of overmethylation. How do genetics play in it? If someone has MTHFR snips, they could be either over or under methylators.
Yes, but also you want to look at the SUOX gene, which is SUOX. SUOX. And that stands for sulfur oxidation. And when you see that, if there's a genetic SNP with that, especially a homozygous SNP, which is both parents, these people cannot handle sulfur compounds. So they may have tried, let's say they have joint pain and they tried MSM. Well, what is MSM? It's a sulfur compound. Or they'll say, every time I eat onions, I don't feel good, or garlic or eggs. And they're just having a lot of issues with sulfur products. And also these people don't detoxify well. So they'll say, oh, I can't go on a detox. It makes me feel terrible. Don't we all have patients like that? You've got all this bunch over here that's doing awesome. And then you got this bunch over here that goes, that didn't work for me. And I gained 10 pounds. Oh, well, nobody wants that phone call, do they? So it can be the SUOX gene if you're doing genetic testing, because if there's a SNP there, they need molybdenum. Okay. And I have something really cool to read you about that. I turned my phone off for the webinar, but I have this really cool thing to read you about that. So we will come back to that in a moment. But yes, high copper, they need the zinc. They need to get rid of the copper exposure, if at all possible. And you need to support them with some molybdenum. And it doesn't really matter, like it's not going to be a huge dose because it's a trace mineral. Usually like in the microgram amount. But anyway, so we'll come back to that in just a second.
Thank you. All right. We're going to go with just one more. Again, the feedback and the comments on here, this has just been amazing to our practitioners here. Last question, and then we'll just go through the rest of it. Can you explain your thinking around the proper ferritin for women being 100 or higher versus the issues of iron overload above 75, especially for non-menstruating women?
Yes. So for a postmenopausal female or someone who's had a hysterectomy, 50 is the level of ferritin that I want. 30 to 50 is fine. Cycling women, though, however, are losing probably a good amount of blood every month, and it's very difficult for their ferritin to ever be over 100 as long as they're having a period. Men, I want it to be the same as a postmenopausal woman, so I want that to be 30 to 50. I've seen that in the 600s, 700s, and up. So that's why we don't obviously want iron overload. But the best way to do that is to just measure ferritin every time you do their labs. And so I've seen ferritin as low as a 2, as I mentioned earlier. 2? Am I going to wait like 6 years for hemoglobin to catch up to that? No way. I'm doing some iron right now and get them to feeling better because it's amazing. But iron overload is a huge problem. Here's the 3 best ways to lower ferritin other than giving blood. Ready? Milk thistle, vitamin A, and turmeric. Now, what if your patients had a cholecystectomy and their gallbladder's gone and they're not absorbing their fat-soluble vitamins? What's going to happen to their vitamin A? Down, okay? They're going to have night blindness. They're going to have conception issues. They're going to have all kinds of problems. But vitamin A controls lactoferrin, which is an enzyme made by the liver that actually lowers vitamin A, iron levels so that they're not toxic, which is incredible. But sometimes if the person has an infection, we're talking about ferritin, the body will lower iron storage because iron can feed bacteria and viruses, and especially parasites too. So the body in its wisdom will lower iron storage because it's fighting off an infection. And so that's why it's important to do a full panel and not just a la carte numbers. So this is what I wanted to mention talking about that copper, but this is very interesting. Okay, so when you see low uric acid, it was talking about molybdenum and why that's important, but listen to this. Aldehyde oxidase, this is AOX, aldehyde oxidase, which in association with xanthine oxidase helps metabolize certain toxins and drugs. It's located in the liver, and molybdenum containing AOX is required for converting acetaldehyde into acetic acid. What is acetaldehyde? It's like one of the most toxic substances on the planet, okay? It's known to compromise brain function and it damages red blood cell membranes. That's why overmethylation can show high bilirubin on a blood test. I was wondering about that. So a patient with Gilbert's or just having high bilirubin can actually be from overmethylation, low molybdenum, and a SUOX SNP that's causing a problem, but they have a molybdenum deficiency, can actually cause high bilirubin on a blood test. I have never heard that mentioned. I love that kind of stuff, okay? But this stuff is bad news. We don't want acetaldehydes. And so the molybdenum deficiency that comes from this can cause the low uric acid you're going to see on a blood test, and opens up a whole new window opportunity for you to look at patients differently. But I thought that was pretty cool. But ferritin, massively important when you're cycling. Other than that, no, we don't want it very high at all. Was that too long of an answer? I hope not.
Dr. Lawrence, can you just go through the next couple slides? There's only a few left with that. If you can scroll through the slides.
Yes.
So of course, now that we've learned about overmethylation and the value of the Dutch test, I would like to review how to order the test before concluding the webinar. This screen is on here too, I think, for so many of our folks on this call here. Ask the doctor, Dr. Wayne Sedano, on the left-hand side of your Vexia account, free email consultation, any help with lab interpretation, questions on clinical conditions. You're just not sure where to start with that. Please reach out to him. He is amazing. Of course, he also offers a live consultation with the Zoom meeting. We do charge for that. The free email consultation, all of that you can find on the left-hand side under Ask the Doctor. And let's go to the next slide. So this is just how to order testing with that. So on the left-hand side, you're going to log into your Avexia account. You're going to register a patient or client that you want to create an order for. Step number 3, you're going to select specialty testing. From that area, you're going to be able to find the products for Dutch under Precision Analytical. So you'll really just add that to the shopping cart and go ahead and check out. Preview the order, and for many of our practitioners, you can either have that order assigned to your client or patient to pay Avexia, or we can build the clinician's account when those results come back. And that should just about be it. How to contact us, 8 a.m. to 8 p.m. Eastern Standard Time, Avexia Diagnostics, live chat is available. Just as a reminder too, we will have all of this recorded. We will definitely get back and answer all those questions. Please let us know if we can help in anything along the way. For any questions or issues, you may contact us either at info@Avexia Diagnostics. Thank you so much, Dr. Lawrence and Dr. Sedano, for this informative presentation. Dr. S., I'm sure you're going to have a lot of feedback in the next couple days. A recording of this webinar will be available by email in the next few days. Thank you again for joining us for this webinar event. Until next time, from everyone at Avexia Diagnostics, stay healthy, stay safe, and we wish you all the best on your pathway to wellness. Thank you so much, Dr. Lawrence. Have a good
Thank
night,
you.
everybody.
May I mention one other book that I recommend?
Yes.
It's called Methylation Madness, and it's specifically about the problem of overmethylators. And my colleague and friend, Patricia Dotson, who is a registered nurse who practices functional medicine in Rifle, Colorado, she's the one that told me about that book. I had no idea it even existed, and it is absolutely wonderful. So it's called Methylation Madness, and the doctor that wrote it is named Terrence Dulin, D-U-L-I-N. I highly recommend that for further reading about overmethylation. Okay. Thank you.
All right. Thank you, everybody. Enjoy your rest of your evening. Thanks again. Good night.